I am absolutely delighted to kick us off. Welcome to the second event in our Liftoff and Motion speaker series. We're so glad you could join us, and also to all the patient safety fellows who are on. We're glad you can join us as well. For those who don't know, my name is Karen Feinstein. I'm President and CEO of the Jewish Healthcare Foundation. Today, we're taking you on a journey that started almost 5 years ago. I love the Consumer Electronics Show, and I get very inspired whenever I go. I look at the opportunities for collaboration across continents, across generations, across disciplines. Some of the greatest health innovators and digital inventors come together with those of us who want to learn and think and be inspired to think of how we solve our problems and make us healthier in new ways. It occurred to us, Mara and Megan, whom some of you may know, when we went to a CES meeting a while ago, that we could be doing this regionally, that you don't have to go to an international event, the largest event in the world, but you can get inspired in your own region, because in our own region, we have some of the greatest inventors and most extraordinary thinkers in the world of both healthcare and technology and digital health. We also knew that maybe we're looking at new education models and a better and a wider appreciation of the assets we have right here. So most of you won't be surprised. That brings us to our event today. And as we know, COVID-19 is also inspiring some new collaborations and innovation right here in the Pittsburgh area. We did hope to have a big summit on December 15th and 16th, as many of you know, to bring together the best thinkers in technology, health, education, entrepreneurship. We will bring them together, but we're not sure it's going to only happen on 2 days. Stay tuned. We are also waiting for the virus to tell us what we should do. But tonight, in the spirit of Liftoff, I bring you one of the not only local great thinkers and leaders in public health, infectious disease to be precise, global infectious disease to be even more precise, Dr. Don Burke. He's not only here, but he has inspired people around the world. So after 25 years as a renowned expert and the former dean of Pitt School of Public Health, he is now the founder of a new company we're going to hear from today, Epidemics. I'm also absolutely delighted that he's brought a colleague with us, John Cordier, with whom he's working. So we're also excited that new ways, we will all be hearing new ways of thinking about behavioral phenomenon, not only diseases, but also substance use disorders and their impact on other behavioral health phenomena. We're also very pleased for those of you who are here because of Liftoff and Motion to know that we have about 70 of our patient safety fellows here as well. So hopefully some way or another, Don and John will be able to inspire a very large cohort of future innovators and some of our leading professionals in process. As we combine all of you together, we get to enter a new world of putting together various specialties and coming up with new ways of approaching our health problems. So it is my pleasure to introduce Dr. Don Burke and John Cordier, Epidemics founders, to share with you their innovation. Thank you.
Well, thank you, Karen and Mara and Megan and the rest of the team for inviting us I'm Don Burke. I'm was the Dean of the Graduate School of Public Health. Now I'm a professor of epidemiology at the Graduate School of Public Health. And uh, my other hat these days is as the co-founder and president and chairman of the board of our new company, Epistemics. Epistemics is named for epistemology. That's the study of knowledge, the nature of knowledge, and we like to think of epistemology as sort of related to our company. That we've created a tool that allows you to think about complicated problems in ways that haven't been previously available. With me is John Cordier. John is the CEO of the company. John, if you want to introduce yourself.
Sure. John, I'm a recent graduate from the Graduate School of Public Health and the Business School at the University of Pittsburgh. I got involved working with Don and our other founder, John Greffenstedt, about 3.5 years ago. And since then, we've gone in several different directions, but right now we're working most notably on the COVID epidemic. And we're going to some of our that we've done with prescriptive client today, and to kind of show off some of our features of FRED and how we approach modeling, and specifically modeling related to the COVID epidemic.
Good, thanks, John. The third co-founder is John Greffenstedt. John Greffenstedt is a computer scientist, his degrees from Pitt and Carnegie Mellon, an old Pittsburgher. John and I have been friends for 25 years. We first crossed paths when we modeled and simulated HIV evolution, him coming at it from a machine learning or artificial intelligence perspective, and I coming at it from a real world epidemiologist. We had such a fantastic time together that it influenced both of our lives. And so we ended up working together for the last 10 years here at Pitt to develop many tools. One of them is FRED. The company's name is Epistemics. The main software platform we use is called FRED. FRED is the framework for reconstructing epidemiological dynamics. It's an agent-based platform. Agent-based means that it's individual-based, that we computationally don't group everybody, but we keep them as separate individuals and keep track of them and allow them to go about their daily business, interact with each other, make decisions, some of which are good, some of which are bad, and contract diseases, have their decisions influence the course of their illness and to influence the course of the community's illnesses. So it's a very powerful tool. So with that, I'll begin. I should also, I'll come back to this, but FRED was named consciously, even though we don't market it this way, is that it's named after Fred Rogers because it's about neighborhoods and communities and people interacting with each other. So agent-based models include each person in the model with contacts in their environment, that they are computationally intensive, meaning you have to use a lot of computer power because you're keeping track of every person. So our FRED has every person in the United States as a separate computational entity with all of their demographic characteristics, and we keep track of all of these are synthetic persons, each of which is sort of like a real person derived from the census. There's Don Burke isn't in it, but there is an agent who is in his early 70s who lives in Squirrel Hill, who has gray hair and otherwise looks a lot like me, but he's scrambled enough that it's not me, and lives in a house with one other person and has an income that's satisfactory. So we do that for all the 300 and some million people in the United States, and keep track of that. So as I say, it's been made possible by the increases in computing power. We study how individuals and their environment interact to create population level behaviors. And as a consequence, we can do the impact of policies and programs for public health. It's designed to run individual-based models. Along the way, we also developed a coding language for agent-based modeling. It's easy to learn. It's based on the English language and the logic and simple logic and syntax rules that we have along with that, the platform for running the programs, the workflow system for managing all of this interactions between people and just the bookkeeping of large-scale simulations. And as I mentioned, we have this detailed census-derived synthetic population. We call it synthetic because it isn't real, but it is intended to represent and closely resemble every person in the United States. Just as sort of a little background on the properties of FRED, it's flexible, extensible. Those of you who are interested, contact me and we'll talk about it, either John or me. We answer questions as more information becomes available. We use real geographies, real populations, and pose real problems. We can take out the synthetic people and put in real people if we want to. So we currently don't use real people just for the sake of the confidentiality and preservation of individual privacy, but we could if people want that. We represent how those individuals, what happens to them, and so as a consequence, we can start to tell stories about individual agents and what happens to them, by keeping track of them in this artificial history. And we can keep adding things onto that. So here's a little outline of what the system of FRED looks like. On the far right, we have the interfaces for FRED, where we've created it so that people can use it on the web or even a mobile device that allows you to access FRED, that you can run a model, you program it yourself, you put that through the databases, it runs on the simulation engine, which can be on any kind of computing platform. And then, but the important part is we have the synthetic population, health conditions, behaviors, policies, initial conditions. FRED is built to be extensible, meaning if you want to, you can write a program yourself and add things to it. And I'm not a programmer, but I have written my own programs in FRED, and it's really fun, to take complicated issues and play them out. In FRED, we have this synthetic population that draws on real-world data from the census and the land use data, Department of Energy, business data, and all of those go together to create this synthetic population where every person lives in a household, goes to work, goes to school, interacts with each other, and can transmit diseases or ideas or beliefs to each other. Here's a map of Allegheny County, downtown Pittsburgh area. It's just color-coded to show you that we have different household sizes. Every household is there, different ages. The ages of each household is represented by the head of the household, income distributions, race, and so we can do simulations of processes down to the neighborhood level with some high specificity. One of the other things that this is a little abstract, but it gets now to some of the powers of what we're doing, is that when you have an infectious disease, you want to know who infects whom. You want to be able to keep track of the processes of what are the spread patterns. And one of the ways of doing that is to create a contact matrix. That is, if you have someone who's an infector and then they infect somebody else who is the infectee. And that process of who infects whom, and I use that because that phrase is used in the infectious disease literature. So maybe a little stilted, but it captures the idea that what you're after is asking the specifics about what are the transmission patterns. And there's this, most of the transmission of diseases, particularly by the respiratory route, are across the ages that are similar. There's a strong age homophily. People in their contact who you see on a daily basis are mostly people like you in your age and sex and race and the like, but particularly in age. And so most of the infections, the red on the heat map, are the persons where the infector and the infectee are the same. And then there are other larger clusters here that are where you have an infector who's 40 or 50 years old, but the infectee is much younger, and those are parents and children. So you get these secondary clusters as well. Point is that even though we talk about this as if it's a real world representation of how people live and where they work and how they go to they go to school and go to work, that you can abstract from that and get this kind of insights into who's interacting with whom. The whole purpose behind creating FRED in the first place was to integrate these interacting systems that are people in households that they have underlying diseases, and we can assign them conditions and states and diseases. That we have the healthcare facilities, we have the public health system represented. We can do things like have pharmacies or other types of special locations that, and it's not that difficult to code up another set of social institutions where people go and interact. I'll get to the COVID in a moment, but here's sort of how you do this stuff. First, to do any kind of model, you first have to have a concept of what do you think the moving parts are. How does disease get introduced into the community? Who infects whom? How do individuals progress through the natural history from stages to stages? And once you've diagrammed that, then you can rough it out in a spreadsheet, or even just with yourself, add some numbers. You code the model into FRED and bring it into the FRED platform. Then you fit your model to the real world data, and I'll show examples of how we did that for COVID. And then now you have a model that you can start to use to ask questions about. And for Allegheny County, what it will show here are some of the effects of varying social distances. We'll show a nice example of a large gathering and simulating of what would happen if we held if the Pirates started their season tomorrow, and what would happen to the transmission patterns. And then we'll take a quick look at King County, Washington, just because we wanted to do other places other than Allegheny County, and there, because nursing homes were such an immediate problem, we illustrate some of how you go about analyzing those transmission patterns. So here are the two epidemics that I mentioned. One is in Allegheny County, in our hometown, and the other is in King County, the Allegheny County. There are three curves there in red that represent deaths and hospitalizations and cases. And then similarly in King County, they have deaths. It was harder for us to get hospitalization, so we just did deaths and cases per day. So that's sort of the starting material where we have to make our model fit these curves so that we have some sort of face validity that the model is doing what we set out to do. The data that we use is straight from the county. The the head epidemiologist there, Luann Brink, is an alum of our school and a regular participant in everything we do at the school in epidemiology. And so we have close ties there. I'm on the Board of Health of Allegheny County. And so the first thing we wanted to do was use those data and to try to develop a simulation. So these are publicly available data sets. Here are the numbers of hospitalizations, number of cases, and number of deaths. In Allegheny County from when the epidemic was first found, 9th of March. We just ran this one through early May. We're updating it now to early June. But that's and this is on a log scale, so that the cases went up. And this is typical that there's about a 2 or 3 week lag between when cases occur and when deaths occur, because that's about how long a person stays ill before they die often. And the hospitalizations have a lag that's somewhat in between those two. So our challenge was to reproduce these numbers for Allegheny County, given the synthetic population and given the likelihood of contact patterns, and how can we make this epidemic appear, and then use that epidemic to ask questions about what ifs we do social distancing, what if we close schools, what else. To do that, it required some understanding of the natural history of COVID-19. You start with people who are either susceptible and immune, and I should say, it's still a fairly dark art, just because the natural history is not that well understood in terms of the likelihood of progression and the factors that influence that. There are these sort of high-level things like age and pre-existing conditions. But if this is a simulation, start on the far left, you're either susceptible or immune, you come in contact with an infectious, the people who are immune don't get infected. The people who do become infected go into a latent state. They stay latent infected for a couple of days. They become asymptomatic infected, and then some of those asymptomatic stay asymptomatic. Others go on to progress to mild or moderate or severe symptoms. That people who have asymptomatic or mild symptoms generally don't have healthcare seeking. People who have moderate symptoms that can be severe, they can be significant in their sick. They'll see a doctor and likely to be diagnosed. Persons who are sick enough to be hospitalized, they have severe symptoms. And then persons with either the moderate symptoms or severe symptoms can die. And so these are all of the states that can be conceptualized as part of the natural history of COVID. And our challenge is to say, well, how long do people stay in each of these states? What's the probability of transitioning between each one of these states? And then can we take those and put these states into our synthetic population and recreate the epidemic from the data that we have in hand? Here are some of the numbers we've put to these. Across the top there, you see exposed, asymptomatic non-progressor, mild non-progressor, moderate non-progressor, severe, and severe non-progressor. The median duration, and these are derived from the literature as it's being reported. This is, and then the relative transmissibility, and I have to say this is still an inexact art. I can tell you that what is known about the viral burden, but I can't tell you that much about what's known of how much transmission. How if you've got 10 to the 6th of viral RNA copies in your respiratory secretions, how does that translate into your relative transmissibility? I think all at this point we can say is if you have more virus, it means you're more likely to transmit. But putting numbers on how transmissible is still, nobody has been able to do that. But nonetheless, we can give this relative ranking, and then by fitting it, we can come up with our best estimates. So you take those numbers of duration and relative transmissibility and put them into the state transition model. And then the next step is to put some transition probabilities on these things. And these are our best interpretations of the literature so far, that of people who become exposed, that about 8% are immune and non-infected, and that is mostly because kids less than 10 years old. It looks like a reasonable percentage of those are immune. By what mechanism, I don't know, whether or not it's because of their prior endemic coronaviruses. I think that's a good bet, but I don't know that. Could be other non-specific immunities. But if you put that all together, most people who are exposed become infected and latently infected. All of those people then go on to be asymptomatic for a couple days, and that they have a reasonable transmissibility. Some of those go on to be asymptomatic and don't progress, and others do progress from asymptomatic to mild to moderate to severe, and this is strongly a function of age. And so this is the overall averages of the state transitions in COVID, but it's that 10-year-olds are very different than 70-year-olds in how they progress down these pathways. So this is a way of describing that those probabilities of progression, that if you're 80 years old, and this is, by the way, down the left, it's a log scale, starting with a probability of 1 going down to a probability of 0.0001, and kids who are 0 to 9 years old have almost a 0 probability of dying. It's not 0, and that there's that as you go up in the ages, the progression probability curve keeps shifting upwards. So that the curve for 80-year-olds, you end up with 20% or more maybe dying, whereas, as I say, the 0 to 9-year-olds, it's very few. So this is what we're aiming to put into the model, and see that this is as close to the real world data as we have, and we're trying to fit this as well as fit the state progressions. One of the ways to fit this is to just tinker it by hand. Another one is we have a collaboration with the National Energy Technology Lab, where they've got a system called NodeWorks that does parameter searches, does a simulation of a simulation to do quick searching for all of these parameters and to see which parameter sets fit together to give you outputs that match the real world data. And some of the parameters that matter the most are not surprisingly, the reproductive number and the import start date and the what the current responses are. And so I won't go into this in detail other than to say that we did do this with the help of a supercomputer and fit our parameters to as best as we can. There are several different combinations that we can choose from. We choose the ones that give us the best fit. And when we do that, across the top here, this is Allegheny County fit to the real world data. That the top are the cumulative curves for deaths and hospitalization and cases. The bottom are the daily counts of deaths and hospitalization and cases. And we get reasonable fit. Where we don't get good fits are on the cases. Is that we estimate lots more cases, so that we have to be able to get to deaths and hospitalization. We just have to have a lot more cases that are not being counted, and that I don't think it comes as a surprise to anybody that what we count as cases is probably many-fold less than cases that are in the world. But we did our best to fit with the real world count. No way to correct for that. Soon we'll be able to correct for that as the antibody data come out that is reliable. And then the other thing is that not only do we have the total cases and hospitalizations and deaths, but we match the relative proportions by age as well. And so we get pretty good fits on the model. And all that does is say, all right, now we've been able to reproduce the epidemic. Now that lets us ask questions. The whole purpose behind this isn't just to produce it, it's to now have a working model that lets us say, what if we change the social distancing, or what if the other policies change? I'm going to pause here for a moment. And John Cordier, do you think there's anything that I should emphasize more that before we go on to the specific scenario analyses?
I don't think so. I think the questions being more functionality of Fred and such. So I think we're good to keep going. I know we have a few questions that have come through. I'm keeping, and we'll be glad to address the questions that people are putting in the chat as we head towards the end.
Yeah, let's. Okay, good. I'm glad I was. In fact, one of the reasons I wanted to pause to make sure people were going to be asking questions, and we'll take them toward the end. So let's look at some of the scenarios of the effects of relaxing social distancing. And there are different scenarios of maintain the current level, resume 100%, and then see what happens, continue the social distancing, but allow large crowds, and then do relax social distancing and allow large crowds. So, as you know, everybody is doing a good job of social distancing now. And so here's the curve fits that we showed you earlier. But now we project them out further and say, well, if we continue the social distancing that we have done now, our reproductive rate remains below 1, and it will work. And of course, the downside of this is the economic consequences. But it's pretty clear that that the social distancing has reduced our reproductive rate below 1, and if we kept doing that, it will stay there if that's what we want to do. So what the next option though is to say, well, what would happen if we were to instead just totally relax the social distancing and leave the schools closed for the summer, but open them in the fall as they would be regularly, and the computational representation show that the epidemic goes through the roof, but much worse than it did during the first wave in the spring. With a unconstrained social distancing, with social mixing, and school opening, I don't think there's any doubt that this could and will take off and overwhelm the system. But that's not a very hard modeling problem. That just so the other way of asking this is that if we do this, that the epidemic would increase, and then we would get this second wave that would come up right away. But here's where I think it starts to get a little more interesting is, oh, okay, well, what happens if we did social distancing, but we did things like allowed ball games to occur, where there would be mixing of people and transmission of infections. And let's look at some of those scenarios. So so here's the idea. What would happen if we had continued social distancing, but we allowed large crowds based on the current and just assume that the infection rates and that the people who attended the ball game would be representative of the infection rate in the community at large. So these are the if you're having a ball game on regular scheduled ball games, the fraction who would become infected at a ball game each time is shown there, and that you'd end up with a fair number of individuals in the orders of many hundreds who would become infected. But the number of infections at a ball game is still a relatively small part of the crowd. And interestingly, that if you've still got the social distancing on, because the overall R0 is less than 1, you put those people back into the community, it doesn't take off. That you're still the social distancing, even with a aggravating event like a ball game, it wouldn't lead to an epidemic. It would lead to local infections in the ball game, and it would lead to a large number of people who could be infected on site. But from a point of view of does it throw the epidemic out of control, the answer is no. And there's so that the large crowds don't present a risk as long as there's a degree of social distancing going on. And in some ways you could argue, well, maybe there's the case that if people want to go do stupid things as a group, then maybe we should let them do that because it's unlikely to ignite a major epidemic. I'm not advocating that, but those are the trade-offs that would be made. But that's just one instance of if social distancing were continued and we allowed large crowds. What would happen if we had large summer gatherings but no social distancing? And instead, we were at a point where the epidemic was hotter than it is now, and we let people go to ball games. Well, obviously, there'd be a lot more infections occurring at the ball games because of the social mixing. And remember, the way we do the agent models is we have people interacting with each other and coming into contact and transmitting. And then what they would do is they would go out to their, let's see if I can get it to go, yeah. So here's there's the orange dot is PNC Park, and there's the number of people who would be infected in large crowd events. And it starts to decrease in part because the epidemic is already going so strongly that we're starting to get to saturation of the total population. So that when you get to a point where infections are commonplace across Allegheny County, a ball game is just another drop in the bucket. It's not a major contributor. So, but you can do that. You can simulate and ask, where did people go and how many secondary cases would there be? So that's the kind of things that we've done with this. So one of the consequences of this is, and I won't call it a paradox, but it's an interesting observation that if your epidemic is under control and you have a ball game, then it doesn't have that great an impact other than the people who go to the game. If you have a raging epidemic and you have a ball game, it doesn't have big an impact because everybody's getting infected anyway. And really, when it really matters is when you're hovering right around an R0 of 1. There, every case has a epidemic payoff of lots of other cases that wouldn't have occurred. And so that's an interesting observation, I think. That a lot of these things matter when when you're skating on the edge, when you're right at the R naught of 1. If you're at the R naught, if you're transmitting a lot, it doesn't matter. If you're transmitting very little, it doesn't matter. But if you're on the edge, it matters a lot. And so there's the epidemics that are with the infections in Allegheny County with and without crowds, and the curves are almost identical. And that's because they're both whopping epidemics, and the crowds don't contribute that much to the total epidemic size. Tell you what I'm going to do. I think we're getting close. I want to pause here and see if we can do questions about our own region before we go on. And if we don't have time for King County, that's fine, because I think that I want to make sure we get into a discussion now. So, John, do you want to, if there are questions that have come up, do you want to take one, or I'll take a look?
I've been following the questions in the chat, and so just start to finish on how they've been coming in. Some of the earlier questions were more on Fred and what sort of data we're using. What's our distinction, or how do we actually define a synthetic population? And then some other questions related to analogies from the ballgame example. So the first question that came through was how is the data synthetic but based on real people? So our synthetic population, we use the word synthetic meaning we're not tracking people in real time. Our data is based on data from the 2010 census, from the other surveys that we mentioned previously, the American Community Survey, Department of Bureau of Labor Statistics data, Department of Education data. And so by synthetic population, we mean that we've recreated in silicon what the population and social dynamics of the United States looks like. We are not tracking people individually. So that data comes from publicly available census and other data sets.
Yeah. So the other point is is that even though they're based on real data, there are no real persons in there. That there are a representation of populations that are very close to what the real population is, but they are not. It isn't the real population.
Right, and so that that was the second question, more or less the same thing. One of the points that Don made earlier is that we can take a real population of people and match that real population to a specific agent that would be the equivalent of that individual. So those are things that we can do. One of the questions was how long does it take a model to run? That's a really good question. The model time duration for it to run is going to be dependent on, one, how complex you build a model, but a general rule of thumb is for a flu model for the entire state of Pennsylvania, running on a laptop takes about 2 to 3 minutes to run. What makes Fred quite efficient in terms of the computing and modeling capabilities is that we have a bookkeeping and management system where agents that are not activated in the simulation, they kind of remain in the background. So that helps with the speed and the time it takes to compute. Now, the next set of questions got into things about COVID. One specific question was on how did we deal with rapidly changing data in the early stage of the pandemic? Don, do you want to take that one on, how we've been able to change the model and the like?
Yeah, so that is that's a problem not only for us, but anybody else who's trying to make sense out of the course of the epidemic. Agent-based simulations have a problem that's a little more acute than some of the data-driven, the statistical models. So the the two models that have been most influential in the United States, one of them was by Neil Ferguson
Sure.
from Imperial, and Neil's been a co-PI of mine, and some background noises there.
Yeah.
Sure.
So
Can you
so
mute?
Neil had a bigger problem than we did because he was starting early on and using only Chinese data. But we keep revising it as we get more data. I went into some detail on the problem of who transmits to whom, how much virus there is, and literally every day I'm finding another paper that somebody is measuring this, not exactly the way we want it, but it's filling out. By posing the natural history in the way we do, I think it helps clarify our thinking. By giving a conceptual model that says these are where we need data, it also helps inform the data collection process. So, but that's a standard problem in this kind of modeling, and it keeps getting better with every passing day.
One other thing to add there is, and that question does come up quite often. When we look at new information that we're going to add to the model, you have to look at what things are really going to shift the end result. And so, you looked at Don's model earlier, and there were probably 12 different states individuals could be in. You could continually add variables to what causes a person to transition from one state to another. But really looking at what the main drivers are, that's an important thing to consider when we're looking at the type of modeling we're doing. There are 400 or so different social determinants that we could factor in. However, all of those aren't being factored in to account for, there might be some that are really mainly showing what's causing the epidemic to continue on, and others have less of a factor, but we can get close enough to representing what's actually going on by keeping the model more simple than adding additional complexity to it. Another question that came up was related to the impact of children and influence of kids on the model. Somebody asked if kids seem to be low risk, but do they serve as vectors for spreading the virus more? Don, I don't know if you want to take that one as well.
That hard as it is to believe this far into the epidemic, that is still not known, and I find that deplorable that we don't know that. Those we should have conducted those studies. Well, the studies that are the best studies that I know of are the contact tracing, where you go into a house and you ask if there's a known person who is in a household, what are the effects on children? Do they become infected? And conversely, you can use contact tracing to say, if a child is infected, what's the likelihood of other people becoming infected in that household? So contact tracing. And my reading of the literature is that kids do become infected, but they become infected about half the rate that adults do for similar types of exposures. And I don't know the reason why that's true. There's lots of data to say that every kid gets particularly up less than age 10, gets a endemic coronavirus infection every year or two. Those are commonplace. The coronaviruses may have some moderate cross protection. That's true of almost every viral family there is. There's a transient 6 months of broad cross protection against like viruses that then disappears over time, and you're left with just straight immunity against the homologous real virus you were exposed to. So if I had to guess, and unfortunately it's in the guess, it's an educated guess, that most of that kids are partially immune, and that most of that partial immunity is from prior endemic coronavirus exposure. But if you challenge me on that, I'd back away in a minute.
One of the other questions that came up was, could we replace the ball game scenario with something like a protest scenario? That answer is yes. That's something that we're definitely considering modeling and will be working on. Another area of questions came in the idea of herd immunity. So related to herd immunity, the question specifically was, what is the effective community infection rate, or number of vaccines, or who needs to be vaccinated to achieve herd immunity, and how does it compare to a pandemic influenza?
So this relates directly to the measurement that gets talked about a lot, which is the reproductive rate of transmission, the R naught. Now, R naught refers to the reproductive rate in a population that is completely pristine, where there's never been an infection before, and then what's the likelihood of transmission? How many cases does each case give rise to? So most of the measurements at the city level for coronavirus, for COVID, come out to be about 2. Some have been higher, some have been lower. And what that means is that you have to have about a protection, so that you have 30% or more have to be protected, and then you can go to a full herd immunity. The conventional formula is 1 minus 1 over R naught, and so but that's a tricky question, in that the R naught varies by population density too. That the closer packed people are, then the higher the probability of transmission. And there are some papers that have said that early in the epidemic that the R naught was closer to 4, and in others it was closer to 1. And that probably accounts for the major differences in the United States so far about who's become infected and who hasn't. So yeah, we've got to use the R naught to our advantage. We've got to try to get to herd immunity, but the problem is that target isn't a single target. It's going to be dependent on the local population density in part. That's okay. We can factor that in. We can give a number to each place. As it turns out, Allegheny County is not a particularly dense county as cities goes. So that may be one of the reasons we've been relatively spared. The other thing is we relatively early on did the shutdowns. Another factor is that we're not an international travel hub, so we probably didn't get as many importations a week or 2 early. All it takes is 2 weeks. If the generation time is roughly 5 days, that is every time that every 5 days you get another R naught. So if your R naught's 3, at the end of 5 days you have 3 cases. At the end of 10 days you have 9 cases. At the end of 15 days you have 27 cases. So just having if you have an R naught of 3 and 2 weeks lead time, you've got a 27-fold difference in your kickoff of the epidemic. So how people reacted early and how fast they reacted made a big difference. So Allegheny County we were in a relatively, I won't say lower risk, but we weren't in the highest risk category as far as counties go.
And that's a good transition to one of the other questions that was on, what happens if half the population follows strict distancing while the other half does not? Again, it's going to depend a lot on the population density of that area and some of the local social dynamics, how you're divvying up the population in half. Is it by age? Is it by specific location? Is it by workplaces or work types? There's a number of questions there, and or is it based on time? Some people can interact all they want in this amount of time, and maybe the 4 days on, 10 days off rule, or when schools are looking at reopening, having Monday, Tuesday, Wednesday students come in, and then another set of students come in Thursday, Friday, Saturday. There's all sorts of ways that you could look at dividing the population in half. And probably the right answer is it's going to be in some combination of those 4 factors. But those are all things that Fred would be able to model. A few other questions came in on, how can Fred be turned into really an education tool, or how can Fred be used to communicate these ideas to the public, and then how is Fred being made available? So certainly, Fred is definitely able to be used as an education tool with the public sector. In a previous example, when there was the measles outbreaks that happened after the event at Disneyland, we created the Fred measles models and created a measles model with 2 different vaccination rates for pretty much every metropolitan area across the country, tweeted out that information, and that information was picked up by a California state senator who then used the measles simulations and showed them to the other state representatives, and it was said and quoted that there was those measles models that actually turned some of the votes on a vaccine bill that this specific senator had introduced. And so certainly, I think one of our most favored uses for Fred is as a public education tool. Don, I don't know if you want to say more to that.
No, it was absolutely, the senator involved was Richard Pan, and he tells me that it was instrumental in his ability to have the other state senators realize when he was able to take a movie like the one I showed of the ballparks, except for measles epidemic for each county. We found out that this was going on because there was an article appeared in Modern Healthcare on that said that the state senator from San Diego just changed his vote because he'd seen the University of Pittsburgh Fred model. And we said, we celebrated. That's exactly what you want. You want your tool that you've created from scratch and put out in general to the populace in a moment where there's a public health problem, in this case, the measles epidemic, and to change votes and change policies. And so we're hoping to be able to do that with COVID.
I guess we're going to have time for 1 or 2 more questions. So if we could answer this one, if there's time, we'll get the second one. So maybe the last question, how the origin of the COVID pandemic changed the model? So the question is specifically asking about, where was the exact origin of the virus? How are people looking at where you import the first case, I guess is the question.
Yeah. So for whatever it's worth, I've been to the Wuhan Institute of Virology. I was there 10, 11 years ago when they were just starting to work on emerging infectious diseases in bats. And I think we probably could have done a better job as a country to increase our collaboration. I think that the current proposal that we cut off funding to them, that we essentially isolate ourselves from the Chinese in terms of scientific discourse, is the absolute worst possible way of approaching this. What we should have had is a greater dialogue. We should have had more scientists back and forth. If there's any concerns about that this was a lab accident, the best way to prevent those are with collaborations and transparency so that everybody else knows what's going on. So I don't think it matters that much in terms of how we model today what the course of the epidemic is. If your purpose is to model how viruses emerge in the first place, where they come from, that's a separate type of problem that I wouldn't use Fred for. I'd use other computational approaches. So I don't think it matters a lot to what we're doing today in the United States about modeling Fred.
Thanks, Don. I think I'm going to have to cut you off. That was absolutely fabulous. Don, if you don't mind stopping your screen share, I want to thank you very much. This is Mara Leff. I'm the Director of Innovation and privileged to lead up the Liftoff team. I'm going to just put on a quick slide here. Again, on behalf of all of us, thank you, Dawn and John, for joining us. We are excited that our next speaker in the series will be Gal Inbar from Israel, joining us on June 30th to talk about some exciting initiatives that he's working on between the innovation happening in Israel and here in Pittsburgh, and building bridges across the two countries. So please do join us. As always, connect with us on social media, and also collected all the questions, and Dawn and John, perhaps if I send them to you, maybe we could get some answers back to some people we weren't able to get to today. Feel free to reach out. I'm happy to connect you with this team. And thank you so much for joining us. And with that, I think we'll sign off. Thank you again, Dr. Burke and John.